for being here still, and thank you for the committee for inviting me to give a presentation of EUROMACS, the European Registry of Assisted Mechanical Circulatory Support. My name is Antonides, and I'm a medical doctor at Erasmus University Medical Center in Rotterdam, the Netherlands. I have no disclosures. What I want to discuss today is the EUROMACS history short and the structure, participation, quality assurance, an update on numbers, current studies we're working on and studies that have been published, and the renewal of software and future goals, which is probably the most exciting part. So in 2006, Intermax started due to the fact that it was obligatory to register patients implanted with an LVAD. And in 2009, EUROMACS was started by an initiative of 9 hospitals. Afterwards, IMAX started, and the goal of IMAX is to reunite Intermax, JMAX, and EUROMACS to have a global database on LVAD patients, or VAD patients actually. EUROMACS joined that, and EUROMACS became part of the ECTS in 2014. And since then, the number of hospitals participating in EUROMACS is continuously growing. And this year we decided that we need some more focus on the pediatric patients, which I will highlight a bit more later. And we also decided to break with the current software and go with new software to serve our purposes. So this is what EUROMACS is structured like. You have the ECTS Council, but mostly important for EUROMACS are all the yellow subcommittees and the committee. Currently, Bart Meijns is the chairman. He's a cardiothoracic surgeon in Leuven, Belgium. And Felix Schöland is the vice chairman, a cardiologist in Berlin. So what are the goals of EUROMACS and the aims? It's a large international database, and the primary purpose is to register data and to be able to do scientific research. We want to extend the quality of the database in such that it meets the needs of individual centers, which means that often centers tell us we like that we can check what data we have, that you visualize what your patients are doing in your center. We want to compare with other centers, but also with other registries. We provide annual reports, and we do quality assurance by statisticians and audits. Currently, we have 69 institutional agreements with hospitals in 19 countries. 1 collective agreement with Spain, and currently there are more agreements in process with individual hospitals, with 3 collective agreements also in process with England, France, and Italy. And of course, as I mentioned, we have the cooperation with IMAX. At the moment, we have over 4,200 implantations registered within EUROMACS, with more than 22,000 follow-ups registered. So what does the database consist of? You have a first implant, and it's a bit weird how it's structured at the moment, but it's a baseline plus post-operative period until discharge or death, for instance. And the follow-up is divided into 2 types of follow-up. You have the routine follow-up, which is basically a patient comes into the outpatient clinic, is seen by a cardiologist, and maybe an echo was done or some lab values were saved. And you have the events, which are major adverse events or small adverse events, such as right heart failure, hemolysis, thrombosis. 2 methods. Small centers often do patient by patient, so they go to the website, they fill it in. And you have also for large centers, you have upload my data, and they have a register which they can upload directly to our website. We do quality assurance by manual checks, statistical checks, so we look at follow-up completeness, outliers, and the follow-up frequency, self-audits, and also on-site audits, which means that myself or Theo de Bie, a colleague of mine, goes to a center and checks whether the data that is filled in EUROMACS is in concordance with the data in their center. Here you see a slide with the volume and the number of hospitals. So as you can see, the most hospitals have a low volume of implantations, and there are few hospitals, 4 to be precise, who have over 300 implantations registered within EUROMACS. If you look at the age distribution, we have 276 children in EUROMACS, and the majority, of course, are adults. Device strategy, and I always think this is a bit interesting. Bridge to transplant, possible bridge to transplant, and destination therapy, of course, are the biggest groups. But recently, if you look at the Elevate study, after 12 months, 2.4% was transplanted. So bridge to transplant is a term that might be evaded later on. If we look at the preoperative INTERMACS class, of course we know by now that the patients with INTERMACS 1 are preferably not directly implanted with a VAD, but still they make up a large amount of patients, and the other are INTERMACS 2 stable, progressive decline, and INTERMACS 3 stable but inotrope dependent. Registered adverse events, as you can see, major infection and major bleeding and device malfunction and neurological dysfunction are the major adverse events. But what always strikes me is that the number of adverse events is 2,985 with over 4,200 patients registered, which means there's a task for us to improve, because I can't believe that on average a patient has 0.6 adverse events during his LVAD life. Causes of death, unfortunately also a large chunk, 29% of the causes of death are unknown. But others are well known, and we also strive to improve this number because we think it's critical to the database. So publications, EUROMACS tries to do an annual report each year, and this year there was also a report, and this is just an example of a graph which looks at survival in different age groups. And this year new, there's also a first pediatric report. And this is a graph of competing outcomes. And as you can see, at 24 months, approximately 50% has been transplanted, about 15% to 20% has deceased, and about 10% has ventricular recovery or wean. If you compare that to the PDMAX, which is the US equivalent, if you only look at the graph, you say, well, these are quite similar, but if you look closely, you see that the follow-up is 12 months, so the transplantation rate is much higher in the US compared to the European countries concerning pediatric patients. Other studies, gender differences in hemodynamics, incidence of thromboembolic events also in the pediatric population by Schwager et al., a development of a right heart failure risk score, and currently there are over 10 studies running, and we hope to have some publications within this year or early next year, all with EUROMACS data. So, the most new part perhaps is we're working on software renewal. We had a difficult relationship with the current software. They are not really flexible, and what we try to do is we're replacing the old system with a new system which is called REDCap, and REDCap is known to you perhaps, but it's developed by Vanderbilt University in the US, and it's used all over the world. It's very flexible, user-friendly, both in setup but also for the users to enter data. It will be hosted at the University Hospital in Birmingham, with which the ECTS has a contract, and fortunately they have 40 statisticians there, which can be very helpful in transferring such a big data set and also doing further research. We want it to be more client-friendly, no discontinuation of research projects. And what we also heard from a lot of users, and rightfully so, is that there are lots of fields which are not filled in and probably not necessary. So what we did a thorough check of all the data fields and decided to remove quite a few data fields because nobody uses them. Maybe some of you are known with the adult cardiac database from ECTS. Similar benchmarking tools will be implemented in the future in EUROMACS as well, which makes it very handy. The adult cardiac database is a large database of over 120,000 patients at the moment. And as a surgeon or a cardiologist, you can look up specific patients with specific comorbidities and compare it to a patient you want to do surgery on or you want to do a specific treatment on. And that's something we aim to do for EUROMACS as well. So you can look up, we've got a patient with INTERMACS 3, these comorbidities, this age. What are the outcomes of these patients? And is it wise to do an LVAD implantation, for instance? Well, this is what I explained a bit already, but what's also interesting is that there's a possibility to expand the registry with specific research topics. And I think in this field, and especially even more so in the pediatric field, this is the way to go. The number of randomized controlled trials is going to be limited due to the limited number of patients. If you want to have high quality data, you need a registry as a basis, but you want to expand certain questions with extra fields. So what we propose, but already some people have proposed research proposals, is that you have 5 to 10 dedicated centers who want to answer a certain question. They use the EUROMACS registry as a basis, and they provide us with additional fields they would like to know to answer their question. And of course, these centers need to be dedicated. With this aim, we hope that we can provide higher quality of data and therefore more power to answer difficult questions in this field. Then another thing which I already highlighted quickly is the PD EUROMACS. As you all know, adult mechanical circulatory support is not the same as pediatric mechanical circulatory support. And this was acknowledged by industry, of course, but also by all the experts in the field. And that's why we decided this year to make a separate PD EUROMACS. For instance, device exchange is completely different compared to the adult population, and also devices used. Short-term devices are used for long-term, and long-term devices are used for short-term. And we want to capture also all the peripherals used when devices are exchanged. For instance, Berlin heart cannulas with a CentriMag, etc. We want to capture all these things, and there was a big shout of help from the pediatric community to get this into the registry, so we're working on that as well. And just as another example, the congenital heart disease is extremely complicated at the moment, and as a consequence, you see that people say, okay, I'm not going to fill this in. This is too, and we always have to keep in mind, this is not only cardiologists, cardiac surgeons, intensivists doing this, but these mainly are vet coordinators, and they think, I don't know, I have to ask supervision, okay, congenital heart disease, that's it. What we want to know is it single ventricular, or at least the groups of congenital heart disease. So the prospective studies, as I said, dedicated centers, and currently there are 2 proposals which will start next year. The TRIS study is a prospective study on anticoagulation regimens used and neurological outcomes in pediatric population. So they use the basis of EUROMACS and in the future PD EUROMACS to answer specific questions. This is not an intervention because each center can use its own coagulation protocol, but what we want to do is prospectively collect what anticoagulation has been used and how are the neurological outcomes. And the EuroACOVAT study is an initiative actually from the center where I work, is a prospective study looking specifically at right heart failure. And as we all know, that's one of the biggest challenges in the future with LVADs. And they try to find more answers on this topic. So what's the timeline? Currently, the database has been tested in REDCap by the University Hospital Birmingham, and they've uploaded the dummy data set, and that was successful. The next step is a beta import of current database to REDCap. So we want to make sure that all data we have, all historical data, is transferred to the new database. Validation of imported database, see whether all the values we have in the new database are the same as we have in the old database. Of course, I think this is one of the critical points, is the communication to users. We take a lot of time in preparation of this. I've been working on this for almost a year and a half now, and hopefully we are finished in the spring next year. But it's critical to have a new system which is better than the previous system, because otherwise adherence will drop, and to communicate it with all the users. So what we're planning to do is have a written tutorial, have a meeting, but also have video tutorials just to explain the new software and go through everything. As I said, spring 2019 is the aim to start, and on that database we want to extend service, as I told, the prospective studies, but also the specific PD EUROMACS database. Thank you for your attention, and I'm happy to answer any questions.